I'm the PGY2 pediatric pharmacy resident, so I'm currently on rotation in the emergency department. So today I'm going to be talking about diabetic ketoacidosis. Do you need me to be louder?
No, just want a second. Keep talking.
Just keep. So, hi, I'm Katie. I'm the PGY2. You good? Okay.
Yeah, just a little echoey, but
there's nothing we can do about that side.
Well, we can put a mic on her and it'll pick up their questions faintly.
I think it's fine.
Okay.
Yeah.
Okay.
All right.
Yeah.
If you're good with it, then.
All right. So we'll go ahead and get started. So the learning objectives for this presentation. So at the conclusion, you should be able to describe the pathophysiology of diabetic ketoacidosis in pediatric patients, recognize the initial signs and symptoms of a pediatric patient with DKA, select an appropriate dosing and monitoring regimen for fluid and insulin therapy in a pediatric patient in the emergency department, and then identify signs and symptoms of complications related to the management of DKA. So first, I'll leave you with a patient case. So we're going to be following this patient throughout the presentation. So KD is a 10-year-old male, 30 kilos, and he presents to triage, being referred from his PCP for a blood glucose reading as high. So he has a history of emesis, lethargy, and weight loss, and he has no significant past medical history. And those are his vital signs up there for you. So we'll refer back to this through the presentation. So what is diabetic ketoacidosis? So it's actually defined based on three components. So it's hyperglycemia plus metabolic acidosis plus ketosis. So hyperglycemia is a serum glucose concentration greater than 200 plus a metabolic acidosis, which is defined as either a venous pH less than 7.3 or a serum bicarb less than 15 plus ketosis. So that's defined as the presence of ketones either in the blood or the urine. So when looking at DKA, we can actually categorize it based on severity. So we have mild DKA, which is a venous pH between 7.3 and 7.2, or a bicarb less than 15. Moderate is a pH between 7.2 and 7.1, or a bicarb concentration less than 10. And then severe is a pH less than 7.1, or a bicarbonate concentration less than 5. So why is severity important? So it actually helps to determine the appropriate level of care for the patient when they present to the emergency department, as well as the risk of complications associated with the management of DKA. So patients that typically present in moderate to severe are generally going to require a higher level of care, such as the PICU, as compared with mild, might be able to be managed in the emergency department alone. So what are the causes of DKA? So usually the main cause we see is undiagnosed diabetes or non-adherence to insulin therapy if they have already been diagnosed with diabetes. An insulin pump malfunction is also common, and then illness, particular GI infections are associated with DKA, and then stress and trauma can also be causes in the pediatric patient population. So how does DKA occur? So in DKA, you have a critical, relative, or absolute deficiency of insulin in the body. And this deficit leads to intercellular starvation. So we have tissues, muscle, liver, and adipose that are dependent on glucose in order to function. And so these tissues end up being starved, and that leads to the stimulation and release of counter-regulatory hormones such as glucagon, catecholamines, cortisol, and growth hormone. And this eventually leads to the stimulation of lipolysis and proteolysis, hepatic and renal glucose production, and hepatic oxidation of fatty acids to ketone bodies. So here's a graphical representation of what happens. So as I said, we have an absolute or relative insulin deficiency, and we kind of follow two pathways. So as I said, those tissues, so the liver, adipose, and muscle, have decreased glucose utilization. So the glucose builds up in the body, and that leads to hyperglycemia. Then on the other side, because we have starvation of those tissues, it leads to lipolysis, so breakdown of fatty acids, which then leads to ketoacidosis because that is a byproduct of lipolysis. And then, because of the counter-regulatory hormones, we also have increased hepatic gluconeogenesis, which further increases your glucose level in the blood. It leads to an osmotic diuresis, which then leads to dehydration, poor perfusion or hypoperfusion, and then lactic acidosis, leading to the overall picture of DKA. So clinical presentation, so how do our patients present with DKA? So the most common presenting symptoms are symptoms of diabetes. So polyuria, polydipsia, and nocturia, as well as nausea, vomiting, and diarrhea are very common in this patient population, as well as any patients presenting with DKA. You can also have signs and symptoms of dehydration. Neurological changes can occur depending on the degree of DKA the patient has. One thing of note is infants, it can actually be difficult to determine if polyuria or polydipsia is present. So these patients are more likely to present with decreased energy or activity and weight loss. So this brings us back to our patient case. So as you can see, while he's been in triage, he's received a few more laboratory tests. So we have an AccuCheck that shows a blood glucose of 680. A urinalysis shows large ketones, and a VBG shows a pH of 7.21, a bicarb of 8, and a potassium of 4.4. So which of Katie's signs and symptoms are indicative of DKA? So I put the case back up there for you. Yeah, so looking at the signs and symptoms that Katie is presenting with, so the emesis, the lethargy, the weight loss, and then we also have the high blood glucose reading from the physician. So next, looking at the laboratory values, so you had already mentioned the pH, the high blood glucose level are all indicative. And then also I'll ask you to calculate what the severity of Katie's DKA is. So we'll put the lab values back up there for you. So do you guys remember?
It's not severe.
So it's not severe.
Moderate was 7.1 to 7.2. Or no?
Yes.
Yes.
Yeah. So if you remember, it's kind of based on these two factors of really what make it mild, moderate, or severe. So with mild, bicarb less than 15. With moderate, the bicarb is less than 10. So even though the pH is still above 7.2, which would technically put you in the moderate category, the bicarb puts him in the moderate category because of that. So yeah, the point of care glucose, the positive ketones in the urinalysis, and then the VBG are all signs of DKA in this patient. And then it is moderate severity. So other things we want to look at and focus on when a patient comes in with DKA is their fluid status. So typically all of these patients that are presenting have an estimated 5 to 10% fluid deficit. So this chart I have up here for you actually kind of shows an example of how you estimate the level of dehydration. So as you can see, patients with mild dehydration, they may just appear normal. You may not necessarily see something that is drastically different in these infants. But as they progress from mild to moderate and then moderate to severe, you can see that there's changes in their blood pressure, their heart rate, compensating for that dehydration, as well as their skin turgor can change depending on their degree of dehydration. Other laboratory findings that we want to investigate are, again, the blood glucose and the urine ketones. And then urgent testing, we want to get a venous blood gas because that helps clue us into what the severity of the DKA is, as well as a BMP plus calcium, phos, and mag, and then a CBC. Other specimens that you can consider getting are blood cultures, urine cultures, or throat culture if a fever or there's some signs or symptoms of a localizing infection. And then considering an electrocardiogram depending on what the potassium on the BMP shows. So there are several complications of diabetic ketoacidosis in general, so without treatment. patients can have an increased risk of peripheral venous thrombosis, fungal infections, rhabdomyolysis, acute pancreatitis, as well as acute renal failure. So you can see a lot of these are very serious complications, so we definitely want to treat the DKA when the patients come in. So that brings us to the management of diabetic ketoacidosis. So first, when we have our patients come in, as you've probably seen in the ED, we always want to do a clinical assessment, regardless of why the patient is coming in. Specifically looking at DKA, we want to look at the vital signs, assess for signs and symptoms of volume depletion, as well as looking and measuring the weight and the height or length, if possible, in these patients. And that's just because in the pediatric population, a lot of our therapies are weight-based, and so it's important to have an updated weight for the patient. And of course, it is always good to perform a neurological assessment in these patients to make sure that we know where their baseline is when they're presenting. So I'm going to walk you through kind of our protocol here at the University of Virginia. So I actually have 2 examples. It's the same protocol, but 2 copies of it here if you guys want to kind of follow along on there. But first thing we want to do is, of course, always obtain IV access and labs when they come in. So depending on what their status is when they come in, the labs may be slightly different. So if a patient is presenting with new onset diabetes with or without DKA, you have specific labs. So there's high priority labs, so labs we do want to get right away when a patient comes in, versus some other labs that I'll go through in just a second. So some of the high priority labs for a patient with new onset diabetes is the diabetes mellitus type 1 evaluation, a hemoglobin A1C, a basic metabolic panel, including MAG, phos, and calcium, a venous blood gas, a urinalysis plus a urine pregnancy test in girls who are of puberty age, and then TSH. And all of these are actually available through order sets. So we have a emergency department pediatric focused DKA order set, as well as a focused admission order set for diabetic ketoacidosis. So some of the lower priority labs that aren't necessarily have to be done up front, but we want to be done during that admission, are if they're less than 2 years of age, considering a celiac, IgG, a CBC with differential, a C-peptide of insulin, and a few other labs. If a patient presents and has known or has a past medical history significant for diabetes, the labs that we obtain in this patient are very similar to those high priority labs that we obtain in the patients that are new onset diabetes with or without DKA. And I forgot to mention this initially, so you'll see that up here it says new onset DKA, unstable, or new onset. So what that means is new onset is a patient that is presenting with diabetes for the first time, so doesn't have a past medical history, whereas unstable means that they're a patient who has a known history of diabetes and is presenting in DKA, so that means that it hasn't been controlled at home. So kind of our 2 main therapies for DKA are insulin as well as fluid. So first we're going to go into the insulin infusions. So in pediatrics, as well as the adult population, we start a regular insulin infusion. The key thing with the pediatric population that's different from the adult population is we don't use a bolus dose of insulin initially. And we don't, in both populations, we don't use rapid acting insulins. So we use regular insulin. So the dose for the pediatric population, again, is based on the actual body weight of the patient. So if the patient is less than 2 years of age, you're going to start at 0.05 units per kilo per hour. And if the patient is greater than 2 years of age, you're going to start at a little bit higher of a concentration at 0.1 units per kilo per hour. And once this insulin infusion is started, you want to check the blood glucose 30 minutes after the start of the infusion, and then every hour while the insulin infusion is running. And this is generally why a lot of patients require a PICU level of care, just because the number of glucose checks that you have to be doing while on an insulin infusion requires PICU level nursing care. So in addition to our regular insulin infusion, we also have basal insulin. So here at UVA, Lantus or insulin glargine is our preferred long-acting insulin. And so it is preferred for Lantus to be administered between the hours of 5 p.m. and 2 a.m. And if you're outside of this window, we want you to consult endocrinology. And this is because endocrinology prefers to administer Lantus in the evening hours for the pediatric population. And it's hard sometimes if it's administered after 2 a.m. to then shift the dosing back to then be an evening time. So that's why we specifically recommend talking to endocrinology, because sometimes they may recommend to do a dose of NPH in order to get you coverage until the evening time to do Lantus administration. So when looking at the dosing for Lantus, so you can continue the home dose of the Lantus if the patient had previously been on Lantus at home, or in new onset patients, you want to start 0.25 units per kilo of actual body weight and it once per day. And this is for all ages. So one thing that doesn't necessarily occur as much in the emergency department, but something that definitely is applicable to the floors and something that is good to consider is, when do you actually transition to subcutaneous insulin? So there's a few parameters that have to be met by the patient in order for them to start thinking about transitioning off of the regular insulin infusion to subcutaneous insulin. So in the patient, we want them to have met, to have the anion gap closed, or the measured bicarbonate to be greater than 16, or the pH to be greater than 7.3. So we want that acidosis that they had to have resolved. We don't want them to have any signs or symptoms of vomiting, nausea, or abdominal pain. We want their mental status to have normalized or have gone back to baseline. And then we want them to have normal perfusion or improved hydration status, and of course a normal pulse rate before considering transitioning to subcutaneous insulin. Another factor that comes into when thinking about transitioning to subcutaneous insulin is when their basal insulin was administered. So if the basal insulin was administered within the past 4 to 24 hours, the insulin infusion can actually be stopped without the need for administering subcutaneous insulin at that point in time. Whereas if there's been no basal insulin, you want to consult endocrinology, because there may need to be additional subcutaneous regimen that is added if they haven't received their basal insulin yet. So that brings us back to our patient case. So which of the following insulin regimens would be appropriate to start for KD? A, insulin 3-unit bolus followed by 1 unit per kilo per hour infusion. B, no bolus, start 0.1 units per kilo per hour infusion. C, insulin 10-unit bolus followed by 0.1 units per kilo per hour infusion. Or D, no bolus, start 0.05 units per kilo per hour infusion.
It's either B or D, no bolus.
So do you remember what delineates the different concentrations? So it's based on age. So you're correct, there is no bolus in the pediatric population, and it's 0.1 units per kilo per hour because our patient is greater than 2 years of age. So if our patient is less than 2 years of age, we want to use that lower infusion rate. So there are a few complications that are associated with insulin therapy, not only in the pediatric population, but the adult population as well. So hypokalemia is actually very common. So in DKA, patients actually have a total body deficit of potassium, and this is due to both renal and gastrointestinal losses. So when they present, the potassium level can actually be normal, increased, or decreased. So potassium typically lives inside of our cells, so it's the main intracellular ion in our cells. And so in DKA, what happens is the potassium is shifted outside of the cell, and so that's why it can appear normal or increased or decreased. So how does hypokalemia happen in the setting of DKA? So there's two main ways. So from our IV fluid resuscitation, this can actually cause the concentration of your potassium to then become normokalemic or mildly hypokalemic after that initial fluid resuscitation. And then also, insulin drives potassium into the cells, resulting in a fall in the serum potassium concentration. So the main treatment for hypokalemia is potassium-containing IV fluids. But one thing of note, if you do have a patient that initially presents with a normal or decreased potassium level, you may have to give additional potassium therapies, just because that again means that it's actually their total body potassium is lower than what their value is actually reflecting. Another complication associated with insulin therapy is hypoglycemia. So in addition to fluids, insulin therapy is necessary to help correct the residual acidosis. So in the setting of DKA, as we said, there's a total body deficit of insulin. And so in these patients, their hyperglycemia or their blood glucose level may correct before their acidosis corrects. But we need that insulin therapy to stay on to help correct the acidosis. So in this setting, insulin acts via specific membrane-bound receptors on those target tissues, so in the liver, the skeletal muscle, and adipose tissue, and increases the uptake of glucose and glucose utilization, so decreasing the serum concentration of glucose. So the main treatment here is the titration of dextrose-containing IV fluids, and this is really dependent upon the serum glucose concentration. And so I'm going to go more into how we do the titration in just a little bit. So this brings us to our initial fluid management. So initially for fluid resuscitation, our goal is reperfusion of the organs. It is not complete restoration of fluid loss. So as I said, these patients are 5 to 10% fluid down. So again, initial fluid resuscitation is just the reperfusion of the organs. It's usually a bolus of normal saline or lactated ringers at 10 mLs per kilo. And this bolus can be repeated if the patient is hypotensive, has poor urine output, or poor perfusion. After the initial fluid resuscitation, we then have our maintenance fluid resuscitation. So the remainder of the fluid deficit is replaced evenly over 48 hours. And we can calculate the fluid replacement based on actual body weight. So there are several different methods out here. You may have heard about the Holiday-Seeger method. So this is one way to calculate maintenance fluid rate in general in the pediatric population. So the way it works is it's the 4-2-1 method. So for the first 10 kilos, you give 4 mLs per kilo per hour. For the second 10 kilos, you give 2 mLs per kilo per hour, and then for every kilo thereafter, you give 1 mL per kilo per hour. You add all of this together, and that gets you your maintenance fluid rate for the patient. So this brings us back to our patient case. So what is Katie's maintenance fluid rate using the Holiday-Seeger method? So we said our patient weighs 30 kilos. So using the 4-2-1 rule. Anybody got a guess?
3.
3. So here, I'll show you. So it's 70 mLs an hour. So how did I get that number? So the patient weighs 30 kilos. So for the first 10 kilos, it's 4 mLs per kilo per hour. So that gives you 40 mLs. Plus 10, so you get 10 kilos. So for the second 10 kilos, it's times 2. So you add those two together, so that gives you 60. And then for the next, any 10 kilos after 20 kilos gives you 1 ml per kilo per hour. So that gives you your total of 70 mLs per hour. So that's the maintenance fluid rate. So in DKA, we actually do something a little bit different. So we actually do 1.5 times maintenance as the fluid rate that we run. You can run up to 2 times maintenance in the pediatric population, but But our protocol here at UVA starts at 1.5, but there are certain times where patients may require more fluid than the 1.5 times maintenance. And so when looking at our initial fluid choices, so if a patient has no urine output or their serum potassium is greater than 6, we want to continue with normal saline. If you want to change the IV fluids once the urine output has been restored and the serum potassium is less than 6. So then you may ask yourself, what fluids do you go to once switching off of normal saline? So here at UVA and most places that take care of pediatric patients, we have what's called the 2-bag system. So this is very different than our adult population. So it's 2 bags of IV fluid that are identical in composition, with the exception that one contains D10 and one does not contain dextrose. So the electrolytes are the same in both bags. The only difference is one contains dextrose, one does not. So the components, or the electrolytes in the bags, are the same, usually containing half normal saline, 50 milliequivalents per liter of sodium acetate, and 27 millimoles per liter of potassium phosphate. And this provides about 40 MEQs of potassium. Now, sometimes these electrolyte concentrations can change, and that's just based on shortages. So I believe right now we have potassium acetate and sodium phos is what's currently in our DKA fluids for the pediatric population. So what information is out there regarding the 2-bag system? So the initial studies when this was first started in the 1990s showed that it resulted in a faster fluid exchange rate. There were less IV fluid bags that were used, as well as reduced cost of IV fluid therapy. More recent studies have started to look at the clinical benefits of using the 2-bag system over the 1-bag system. And here they've shown that it's decreased the duration of insulin therapy, the number of adjustments to the insulin rate, as well as the number of wasted IV fluid bags. And it showed these benefits without increasing the incidence of the complications of hypoglycemia, hypokalemia, and cerebral edema. So and colleagues actually looked at comparing the 2-bag system in pediatric patients to the 1-bag system and looking at the clinical benefits. So they looked at the rate of complete blood glucose correction, the rate of bicarbonate correction, the time to pH correction, and the time to ketone correction. As you can see, for bicarbonate and ketone, there was a statistically significant difference in favor of the 2-bag system over the 1-bag system. There was no statistically significant difference in the rate of complete blood glucose correction or the time to pH correction. However, the authors go on to say that the rate of bicarb and ketone correction can be extrapolated to kind of indicate that it can possibly lead to a decrease in length of hospital stay, as well as length of ICU stay for these patients. So there's further studies that are still trying to prove that it does decrease length of hospital stay in these patients. So this brings us back to our patient case. So which of the following fluid regimens would be appropriate to start for KD? So a 3-liter normal saline bolus only. B, no bolus, start non-dextrose containing fluids at 105 mLs an hour. C, 30 mLs normal saline bolus followed by an infusion of non-dextrose containing fluids at 70 mLs an hour. Or D, 30 mLs normal saline bolus followed by an infusion at 105 mLs an hour of non-dextrose containing fluids.
B.
So B is actually incorrect. So I know I kind of threw a curveball at you guys. So in the pediatric population, we actually do a bolus. And the bolus is 10 mLs per kilo of normal saline or lactated ringers. And then in this case, the patient still had that initial blood glucose of 600. So you'd want to start non-dextrose containing fluids at 105 mLs an hour, which is 1.5 times maintenance. So C is incorrect because 70 mLs an hour would be 1 times maintenance. And then 3 liters is a large amount of fluid to be given. So here kind of clarifies how you titrate your fluids, both the non-dextrose and the dextrose-containing fluids. So once urine output has been restored or the serum potassium is less than 6, the titration of your fluids is based on what your blood glucose level is. So if the point of care glucose is greater than 100 or greater than 300, you're going to be running the non-dextrose containing fluids at 1.5 times maintenance. If your blood glucose is between 200 and 300, you're going to have a 50-50 split between the non-dextrose containing fluids and the dextrose containing fluids. So in the case of our patient, you have 105 mLs an hour is 1.5 times maintenance. So it's going to be 52.5 mLs split between the 2 fluids. And then of course, if your blood glucose is less than 200, you're going to infuse only the dextrose containing fluids. So that brings us to our next case, or same case. So 2 hours later, Katie's point of care blood glucose is 250. Which of the following fluid regimens would be appropriate for Katie? So less than 200, you would run dextrose containing fluids.
So the non-dextrose at this point. Yeah, A.
Okay. So it's kind of hard to remember, and this is all written down for you guys in the protocol. So think of it as 200 and below is dextrose only, 300 and above is non-dextrose. So anything in between is going to be a mix between your dextrose and your non-dextrose containing fluids. So because it's 250, you're going to split the maintenance rate, so 52.5 mLs per hour of the dextrose containing fluids, and then the other half at 52.5 mLs an hour is going to be your non-dextrose containing fluids. So here, the key thing about the 2-bag system, it gives an individual rate of dextrose, and it allows you to titrate based on what the patient's blood glucose is. So as we said before, the hyperglycemia is going to resolve before the acidosis does. So we want to target a goal blood glucose somewhere between 100 and 250. And one key thing to point out is that after our initial bolus or fluid resuscitation, we want to make sure that the glucose concentration does not decrease by more than 100 every hour. So if you start at 600 at the top of the hour, the next hour you want to make sure that you're not below 500. And this is just because it can cause shifts in fluid and lead to some of our complications that I'll go into in just a second. So the main complication that's associated with fluid shifts, and the most serious frequent complication in DKA in the pediatric population, is cerebral edema. So it occurs in approximately 1% of pediatric DKA episodes, and usually occurs within 12 hours, but up to 24 hours following the initiation of treatment for DKA. So the outcomes, there's 21 to 24% mortality associated with cerebral edema, and then there's 21 to 26% permanent neurological damage that can be associated with cerebral edema. Some of the studies actually suggest that all patients present, or most patients that present, actually have mild subclinical cerebral edema. However, only 1% or fewer actually progress to the point or have a degree of cerebral edema sufficient to cause CNS dysfunction. So how does cerebral edema occur in the treatment of DKA? So really the cause or the etiology is not fully understood. They think it's attributed to rapid changes in serum osmolality, which can occur if you drop the blood glucose concentration too fast, or overly vigorous fluid resuscitation. When looking at risk factors, so our younger age patients are more at risk, new onset, as well as severe DKA, both severe dehydration and severe acidosis, and then again, the rapid fall in osmolality. When looking at the signs and symptoms of cerebral edema, so the minor criteria or the earlier signs of cerebral edema can be headache, emesis, or irritability in the patient, or lethargy or not easily arousable. Major criteria, which kind of indicates that the patient is already having ongoing neurological damage, is abnormal or deteriorating mental status after the initiation of therapy, incontinence inappropriate for age, decreased oxygen saturations, or an abnormal respiratory pattern. So the key thing here is prevention. So we need to be careful with our fluid administration, and that's why the current guidelines recommend the more gradual replacement. So that's why our initial fluid bolus goal is only for reperfusion of the organs, and then we have the remaining fluid deficit administered over 48 hours. So the main treatment for cerebral edema is you want to decrease the IV fluid rate by 50%, use either mannitol or hypertonic 3% saline, and then considering intubation with gentle hyperventilation if the patient requires it. So this brings us to the conclusion of our presentation. So there's a few goals when thinking about the management of DKA. So one of our main goals is restoration of perfusion. So by restoring perfusion in these patients, it leads to an increase in glucose uptake in the periphery, an increased glomerular filtration, and then reversal of that progressive acidosis that they have ongoing. We also want to arrest the ketogenesis that's occurring with the insulin administration. And so by administering the insulin, we're able to reverse the proteolysis and the lipolysis that's occurring, while then again stimulating the uptake of glucose into the cells and normalizing the serum blood glucose concentration. And then of course, we also want to replace electrolyte losses in these patients. So just a few clinical pearls to think about in the pediatric population. So again, DKA is the result of a critical relative or absolute deficit of insulin. The two-bag system is the preferred method for fluid administration, and this allows you to have a patient-specific rate of dextrose infusion. And then insulin in the pediatric population should not be given as a bolus, but it should be infused after the initial fluid resuscitation. And then when it comes to Lantus administration, it should occur between the hours of 5 p.m. and 2 a.m. And if not, we want you to consult endocrinology. And then of course, cerebral edema is the most serious complication of DKA, and it requires careful neurological and vital sign monitoring. All right, and that concludes the presentation. What questions do you have for me?
So checking blood glucose values is like 30 minutes after, and then every hour at that point.
Correct.
And then I guess whenever we start to get concerned about any kind of other neuro.
Yeah, so you will be set when you have the insulin infusion when it started, again, the 30 minutes as you said, and then every hour after that. But if for some reason you're concerned that they are hypoglycemic, then you can always check a point of care.
Too fast.
Mm-hmm.
Yeah.
So is the cerebral edema only due to over resuscitation of fluids, or like it's not an actual like disease progression, is it?
It is not typically a disease progression. It is because of the management of DKA that causes the cerebral edema. So there's a lot of different theories out there, but the main one has to do with the overly aggressive fluid resuscitation and causing fluid shifts leading to the cerebral edema.
And I think that's one thing that's a stark contrast between adult and pediatric management of DKA. So it's something as you guys progress in your career, if you decide to treat pediatric patients as well, something that's important to note. And as Michelle will talk about in a minute, we don't have to be nearly as careful with fluid resuscitation in adults, absent renal or renal dysfunction or heart failure or something like that.
Great. Well, thank you.